This is Professor Ariel Ortiz Lagardere streaming live from the International Bariatric Club studios, and I am delighted to announce today's the 111th IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford, with the aim of these webinars is to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford has allocated September 8th through the 10th of 2025 as the dates for the 6th IBC University of Oxford World Congress to be held at the Examination Schools, University of Oxford. And for more information, please go to ibcclub.org. The theme of today's multi-streamed 111th IBC University of Oxford Hot Topics in Bariatric Surgery exclusive webinar is the A to Z in training in robotic bariatric and foregut surgery, and will feature experts from the United States, the United Kingdom, Brazil, Portugal, and Spain. The IBC University of Oxford webinar partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, Medtronic, David Medical, our gold sponsors, Johnson & Johnson MedTech, Teleflex, Arthrex, USGI Medical, XNY Medical, ConMed, Reach Surgical, Karl Storz, Blue Sail Surgical, our silver sponsors, GT Metabolic Solutions, our bronze sponsors, Intuitive. Our chairs today are Dr. Keith Kim from the United States and Mr. Bruno Sgromo from the United Kingdom. Dr. Keith Kim is a pioneer and robotic bariatric surgeon, having performed over 3,000 robotic bariatric surgeries. Editor of Robotics in General Surgery, one of the first comprehensive textbooks on robotic approaches in general surgery, and co-editor of Robotic Bariatric Surgery. Mr. Bruno Sgromo is consultant esophagogastric cancer bariatric and general surgeon at the Oxford Radcliffe NHS Trust, United Kingdom, also co-founder of and co-director of IBC Oxford University World Congress and co-director of IBC Oxford University webinars. I will now ask Dr. Kim to introduce our esteemed moderators.
Thank you. Thank you, Dr. Ortiz and Dr. Harris for putting on this amazing program, and also thank you, Ms. Miranda, for all your behind-the-scenes work. It's certainly an honor to be included with such a distinguished panel. I would like to introduce our three moderators. They are certainly exceptionally accomplished robotic surgeons, and appropriate to this topic, collectively they have mentored hundreds of surgeons around the world. It is also my great pleasure to call them my very dear friends. First, we have Professor Paula Volpe, who is a consultant in gastrointestinal, metabolic, and robotic surgery at the Luiz Itaim Hospital in Sao Paulo, Brazil. Next, we have Professor Carlos Vaz from Lisbon, Portugal, where he is the director of the Bariatric and Metabolic Surgery Center, as well as head of the robotic program at the Hospital CUF Infante Santo. And last but not least, we have Professor Luiz Alfredo de Almeida from Rio de Janeiro in Brazil. He is a consultant in gastrointestinal, bariatric, and robotic surgery at the America Medical City, and he is also affiliated with IRCAD Latin America, as well as a course director at IRCAD in Strasbourg, France.
Hello, everyone, and thanks for joining us. It is my great pleasure to introduce Dr. Hani Takla, who is a good friend and a regular at the Oxford annual conference. Hani is an attending robotic bariatric and general surgeon at the Orlando Health Weight Loss and Bariatric Surgery Institute, Florida, United States of America. Thank you, Hani. Please, the floor is yours.
Thank you, Bruno. Thank you again to the IBC and Harris and Ariel and Bruno for for the kind invitation, and always happy to serve. So I'm going to try to share my screen. Make sure. All right. So that's showing okay. Good.
Yes, we can see it.
Yes.
Okay, all right. So I was asked about talking about starting with simplicity, online and virtual reality training for robotic bariatric surgery. These are my disclosures. I recently joined this group in Orlando Health, Weight Loss and Bariatric Surgery Institute, a group of great surgeons and friends. And it's kind of timely because we just got approved for a second fellowship spot at our program, and we also have residents that rotate. So just wanted to give background a little bit and where is robotic surgery or robotic bariatric surgery training these days? And this paper from Mike A. Watt and Surgical Endoscopy recently sort of talked about targeted educational resources. So what they did is that they provided their trainees with pictures and videos of the bariatric procedures that they're doing, and sort of distributed that to the residents and just kind of saw how they did. And with tracking the information through different apps on robotic platforms, it showed that the residents that were provided with these picture and visual guides of the procedure, the steps of the procedure, actually did more of the procedure, or at least more minutes hands-on in the robotic platform, which could be tracked easily through the app. Which means that most of I guess the newer generation, including myself and others, learn better with sort of visual or picture or video cues. The other two papers, one was also surgical endoscopy, and the other was in SWORD about the participation of trainees, whether it's residents or fellows, in bariatric surgery. And obviously, as we all expect, most of these procedures did take longer, but there was not major complications. There was overall complication was a little bit higher, but not the major complication things like leaks or reoperations. These did not exist actually for these trainees, or was actually very close to normal. So it tells you that sort of, we are, obviously obligated to have residents and fellows participate in procedures, but their participation, as long as it's, kept track for by their attending, it doesn't change the outcomes that much. So what are the challenges? I think this day and age, it's definitely limited exposure due to the volumes, especially the recent decrease in volumes that we're seeing. Limited training hours in residency program in the United States. Also, sort of the residency training hours per week are less than what it used to be. And also, I think, in my opinion, some generational changes where there's sort of less, I mean, I might be a little bit harsh to say that, but there's a little bit less investment in learning from the trainees themselves. And there are ways to sort of deal with that where we could provide different platforms of learning, which I'm going to show, and more reliance on video and on-the-go training, as I showed with Dr. Awad's recent training. So how can we improve this as, sort of a surgeons community? The IBC and other platforms are great platforms, in my opinion. There's some of the ASMBS Fellow Project is also very good. Some of these collaborations online. But participating in these, I always encourage the residents and fellows to participate in them, because you could get, criticism or positive feedback sometimes, which helps. And then establishing these boot camps in each site, obviously in conjunction with industry, because, there's a lot of that goes into it in terms of finances, etc. And in my opinion, in the future, reliance on virtual reality, but also AI in training the next generation. Establishing friendship or a mentor-mentee friendship relationship, I think goes a long way with our trainees. When I see someone and meet them in a meeting, and we sort of go out and have fun and talk about surgery and life in general, goes a long way with training. And I think the suggested steps is to start with sort of simulation virtual reality, like all the platforms that are available. Usually the next step is to do a dry lab and hands-on courses, and then sort of live cases and break them into steps. And long-term, after the resident or fellow graduates and they go into practice, is continued mentorship and through tele-mentoring platforms. I'm going to show a little bit of videos. This is, for example, the Fundamental VR have this platform that sort of takes you through how to set up a robotic platform. And they do have that for certain robots that are available now, but it shows you that you could, from the trainee just sitting at home or at their office, they can actually go through the steps of docking and how to place the different arms of the robot, and do that even virtually. It doesn't have to necessarily be hands-on, which is a great difference between, when we trained and now in robotics, that you could actually do this. You could actually do this, hands-on, or if you're in a remote area, if you're trying to, do some time, in your office and such, you can do that, and it's very easy. And also some of these sort of virtual reality. Oh, I'm sorry. I'm sorry about the music, but it basically trying to, do these different exercises from basic steps like suturing and stapling and breaking, procedures into steps. These platforms are also available. And also, different companies have different platforms. So Intuitive, for example, have the sim now, which has improved very much, where you could, have trainees try these different steps of the procedures along the way. Next step is sort of hands-on dry lab thing, and this is from my good friend Mario Gonçalves. You guys all probably met with him, but he has First Touch Academy. They go through different procedures, different steps, and this is sort of their bariatric module. Where moving on from virtual reality models, they sort of go into dry lab and doing things hands-on. So the first step is to observe live surgery. And sort of to go over the steps in live surgery, and then they go to the lab and do the simulation. But the simulation is not a virtual reality; it's actual synthetic models that are easy to do, and they're made of synthetic material, so it doesn't involve an animal lab and such. So they can actually, the resident fellow could actually check out this model and just take it at home and practice on it. And obviously different companies provide the different instruments that could do. So as you can see, they have different modules for hernia, for biliary, for bariatrics, and I think it's a great training tool for residents and fellows. And this is part of the course that we did in Boston Mint this year, and we sort of used some of these platforms. And I think integration of AI is coming. It's happening already, and I think this is, for example, a gastric bypass, and I think in the future we'll be able to highlight some tips and tricks to the trainee over the video, and this is coming and happening already with some companies where you could actually overlay. This is showing, for example, the bougie going in, what would be the next step of the procedure. Things like finding the ligament of Treitz and highlighting that, and I think AI will be able to do that. And this is actually pictures from some of the work that we've been trying to do with other companies, trying to identify structures, display next steps of the procedure, and also if the AI is seeing that you need to do a hand adjustment, for example. And this is, for example, doing the JJ. So I sort of try to turn my hand a little bit when I do that. So to make sure that it's going anti-mesenteric border to anti-mesenteric border. So here, the AI identified that I'm going transverse a little bit, so it's telling me to sort of turn my hand. So all of these things will be very helpful for trainees in the future, not just during training, but during doing live surgery as well, where you could turn on the AI platform, etc. And this is also another, type of AI that helps in learning and measuring the bowel length. So it's basically identifying what's the length between the two hands and giving you the measurement at the end. And you could always sort of corroborate that with your own measurements. You could add a measuring tape. But all of these platforms that I'm showing, or these software that I'm showing, is actually in development, is happening these days. And last but not least, after the trainee is done with all these steps, whether it's virtual, dry lab, and hands-on during surgery or during the operation, then telementoring after they graduate. So after they go out in training, there's a lot of platforms. So Proximie is one of them, but there's a lot of other platforms that are available, even some of them with the Apple glasses. I can't remember its name, but the Apple glasses that you could wear, and it could take you to an operating room and actually be able to point things and to your trainees after they graduate. So I think, future is involving the trainees in their own training. I think that's a most important thing. Most of people need to invest their time and effort, and that's a very important message to carry to our trainees, is that they need to invest the time to be able to learn. Obviously, partnership with industry to allow for easy adoption of these different platforms that are helpful. Newer tools such as virtual reality and AI to facilitate that training, and continued mentorship and telementoring, keeping a relationship with your trainees when they graduate, so that they can actually carry forward what they train to do. And I think I'm out of time, or about time, so thank you.
Thank you for a very nice talk. Congratulations on your talk. You touched on several things, but I was just curious, in your own fellowship program, do you have required modules and time spent on simulators in dry labs? And then secondly, do you think that's something that we should push to standardize, so that like all fellowship programs should have requirements on simulators as well as dry labs before they actually get on a system?
Yeah, that's a good question. Actually, in fact, before, a few weeks before this meeting, when we got approval for the second fellow, we sort of sat down and said, hey, we need to basically do this and make sure that they have all of these steps to go through, because currently we don't have that. And I think it's helpful. There are a lot of residency programs that did that. UAB, for example, John Porterfield, they have certain requirements on, like, if in order to be, in your first year, you have to finish the modules, they have to be, whatever percentage pass rate on it before you go on to do this or before you go on to the next step. So it has to be structured, I think. And I think our roles as, societies and such that provide that guidance, what do we think will help bariatric fellows, for example, to do, this procedure, and try to figure out what modules they could use. And with the newer simulators, they're very, very, they're not very realistic, but as close to reality as possible. And taking them through the steps of virtual, followed by dry lab, I think sort of takes them into the next step. So that's kind of my long answer to your question, I guess.
You talked about a little bit about telementoring at the final part of the learning process, and what about it's not yet in our Occidental platforms, but telesurgery is coming. And it's already available on some Chinese platforms. Namely, there is one platform, it's called Tumai, that you can already perform telesurgery. What about this telementoring with these new platforms? We are not thinking about it because we are focused on what we have, but it's really already available. It's just not certified, but I think it's already certified for Europe. I don't know what will happen with the FDA, but I think we should think about those new platforms that are just coming, and it seems that they are good. I think that for telementoring, this a new platform that allows you to do telesurgery, it will be a better telementoring, I would say.
Yeah, definitely. I mean, even now when I'm, when I go to proctor a case locally or in a different state, we don't get credentialed, and that's a big problem, because if there's something that you could or should intervene in, technically you can't do that. So it would be great if it's available, but like you said, I think from the regulation standpoint, it's going to take a while, especially in the US, but it will happen for sure, I think. So it'll be part of the telementoring, I guess.
Dr. Takla, nice speak, very, very good speak. Please, I have one question. What about this virtual training? We don't have experience actually, and I can't see. I was trained by Dr. Kate Keane. We simulate a lot. We're doing operations with the proctors. I can't see in my because we don't have any kind of we don't have any established publication talking about virtual training. How is your point about how can you see how it improve how it makes some difference in terms of virtual training?
I don't think it actually, my personal opinion, and some companies might hate me for that. I think the virtual trainers, like the ones that I showed, are not realistic. They're not high fidelity things. I think a lot of the moves and a lot of the tissue drag and that sort of thing is non-realistic at all. But I think at least it's a step. It takes the trainee through, okay, the first step, create the pouch, go in the perigastric dissection, divide with a stapler. It takes them through the steps, but I'm not saying that it, that's why I think it should be a stepwise approach where you go from, virtual reality to dry lab, then to maybe wet lab, and then to surgery or something along those lines. I personally, in my days when I trained in robotics, I did, we only had the little games on the old simulator. And I've tried the new simulator, and I just don't think it's that good, honestly. And I don't know how they could make it better, because it's really doing a virtual reality game. But I think it's at least a step to get the trainee from, if they didn't have any background, for example, I can tell you, we had one fellow that had, you know, a lot of robotic exposure in the residency. When they were in fellowship, they sort of almost hit the ground running, where they needed to learn the steps of operations and how to do just very little things. But if they don't have background at all, they haven't had exposure to robotics in residency, it becomes, you know, harder to sort of get them into surgery right away and that sort of thing. So I think that gets them a little bit of a head start. If we require them to do these things beforehand, then it gives them a head start where they could actually, you know, and it's a 1-year fellowship, so they need some, you know, need to move on.
Thank you.
Great talk, Hani. I totally agree with you. And I believe that the virtual reality and AI will, in that training, will improve a lot. But we know that that beginner surgeons want to sit at the console. My question, simple question, is how do we convince the surgeon to go through this step? Because it's boring.
Well, I think that they're trying to make it more attractive. So it used to be just like games, and now it's operations. So I think, I mean, it also would have to come in from like sort of credentialing bodies where we are. You know, the credential committee might require someone to do X, Y, and Z. My previous job, for example, we required people to do even the basic simulator and pass certain things like needle passing and stuff about at 80% if they didn't have any previous training. Things like that. So I think it will happen, but at least the companies are doing the extra effort trying to introduce actual procedures rather than just games on the simulator.
Thank you.
I think that we can go on, and our next speaker is will be Professor Ann Rogers from United States. Professor Ann Rogers will talk about console-based skill simulators and wet lab training. Professor Ann Rogers is the president of ASMBS, professor of surgery and director of Penn State Surgical Weight Loss Program, and vice chair for Faculty Development Division of Minimally Invasive Surgery Bariatrics, Penn Health, Pennsylvania, United States. Please.
Thanks, Paula. That's great. I'm going to share my talk. Hopefully it can be seen. I thought there was going to be a great deal of overlap between my talk and Hani's, but they're a little bit different. These are my disclosures. I'm going to try to have them not be important. So, you know, robotics is growing, and it appears that about 50% of general surgery is being done robotically now. So everybody needs to be trained before they adopt technology. And, you know, in the olden days, it was see one, do one, teach one. This is not true anymore, especially with complex platforms like this. And Hani talked about the different kinds of training that exist. I'm going to be talking about simulation and wet labs. And this is a protocol that has opened up. They don't have any results, but they're acquiring data about what would be a valuable way of training people. But there are some papers. This one was about a robotic cardiac surgery simulation training program. They had 40 residents. They all had fewer than 10 hours exposure to thoracic robotics, and they were shown a 5-minute video done by an expert of a robotically harvested internal thoracic artery, and then they got a video on a robotic-assisted mitral valve annuloplasty, and the people were talking while they were doing these videos. They highlighted not just the operative technique, but the relevant anatomy. So then these 40 residents themselves did a dissection of a porcine internal thoracic artery, and then they placed 3 sutures of a porcine mitral valve. So they got hands-on experience doing that. And then the 40 people were randomized to one of 4 training streams. One went into the wet lab, one got dry lab, one got the virtual reality, and the poor control people, they got nothing. So I wonder who did better. So the wet lab was just the original porcine model, and they had figured out by watching these fellowship-trained expert robotic surgeons do it over and over and over again what would be expected, and they used a scoring system that basically came out of the FLS program. And then the dry lab was also FLS type tasks where they were, cutting paper and peg transfer and knot tying and whatnot. And, this is an example of dry lab. I had to do this a million years ago when I went to a course in like 2008 offered by Allergan about how to place and access bands, and they had this piece of blubber and you're supposed to put the port under it and access it with a needle. And there was a guy there screaming at his PA that failure was not an option. So I love that. Anyway, so the virtual reality training was done on the DaVinci simulator. And so the experts chose a 9-exercise curriculum, and it has a lot more than that. And they set the proficiency at 90% or greater, and they couldn't have any critical errors. And I must say, when I was going through my second round of in robotic training, we had to get 90% in order to be allowed to go to the pig or cadaver lab. And the first time I went through this was in 2010 with Dr. Keith Kim when I was learning on the SI, which I didn't adopt, but there you go. So interestingly, with the wet lab training, the scores were significantly better than those of the experts by the time they got to the end of the assessment. And that was in like 3 or 4 weeks. So the experts were the white bar. The wet lab was the black bar. They actually were shown to be better at doing the operation than the experts. And then a close second was the people that did the virtual reality simulation. So that's pretty amazing, So and the reason for that, and when I say virtual reality, I don't mean anything special. I just mean the simulator that you can buy from the robot company itself. But it gives you ways of improving your proficiency by monitoring a bunch of things like how far you're going with your instruments and whatnot. So it's more than just how quickly you can do it. It's how accurately you can do it. So then we have pig models, and we've all gone to pig labs and whatnot. And, there are some problems with porcine models for robotic training, one of which is it's not the same size as an adult size human. It's kind of long and skinny. The organs are not exactly the same layout or shape. Certainly the toughness or the actual tissue handling is not the same. For instance, a pig stomach is hard as a rock, so it's hard to staple through it. So it's not a great thing. And then there are, of course, issues of animal cruelty and PETA trying to find out what's going on. So, it's not necessarily the greatest. So this paper looked at it, and they basically said there are considerable limitations to live animal simulations, such as cost, and you have to have full veterinary support. And I've done a lot of animal research in my time at Penn State, and you do have to have a real live animal facility that's ventilated and spacious, and it's just hard to maintain. This is the Penn State Hershey Medical Center. So somewhere back there behind the medical center in the green part is hidden our animal research facility. And you get to it through this horrifying tunnel that's literally a mile long. And they have these broken down bicycles at each end that you can kind of ride back and forth. But and it's to keep people from finding it and blowing it up, because we do quite a bit of large animal research there. And then we have cadavers. Okay, so we all know about cadavers, but they've been in use in medical schools and, for 200 years, and have been very, very maximally utilized in both laparoscopic and robotic training. Usually in robotic training, they use fresh frozen cadaver torsos, and they, at the very least, show you human size and shape and something about tissue handling. And and this sort of came to be a problem during the pandemic because they couldn't actually test cadavers for the presence of COVID. So then a bunch of companies started getting concerned about continuing to use cadavers. And I do think that Intuitive uses them to some extent for resident labs, but they have to be quite careful. And in fact, they have actual perfused cadavers and perfused organ blocks where you can plug it in. And so if you do the wrong thing, it'll actually bleed. But these things are very, very expensive. So then there's something called Syndaver, and this is something that Intuitive is using. I'll go back to it. I'll play it very briefly. Apparently my audio can't be heard, but this is a realistic looking thing that Intuitive does use for some of their labs. And I think a lot of other places are using them too. I'm so glad you can't hear the cheesy porno soundtrack, but but these things
The
handle
Never Labs designed
quite
and
a
built
lot
the world's most
like
sophisticated
living
synthetic
tissue.
human tissues
So
and body parts.
that's kind of cool. That does exist, but they're very expensive. $70,000 a pop. Yeah, that's not cheap. So then we have these synthetic organs that can be used for robotic surgery education. And, so basically this paper said there's very little evidence to support the use of pigs or cadavers. It's just there are too many logistical, ethical, financial, and infection control issues. So this whole thing about real tissue robotic simulation is coming to be more in favor. There's a company called Kindheart in North Carolina that makes organ blocks that are basically porcine, but they've been treated in a variety of ways so they can be used and they're more likely to be able to simulate human handling.
This simulator allows for the performance of all bariatric
this is a
procedures,
Kindheart
such as
simulator
sleeve
for
gastrectomy or
practicing a
Roux-en-Y gastric
sleeve.
bypass.
I'm so glad you can't hear the horrible porno soundtrack. But here they are attempting to do a gastric bypass and whatnot,
Plus,
so it doesn't
anti-reflux
bleed,
procedures such as
but
radiation,
it's been treated in such a way
and
that it
esophageal
works better
bariatrics.
with the equipment.
The esophagus is.
And they have it on a block and then they put it
and,
inside a human
here is
body
the
shaped
liver,
thing. So it's a
the
little
omentum,
closer
and spleen.
to dealing with
14
real
organ
tissue
tissue
than
blocks has been
certainly
modified by Kindheart
some of the
to
simulator
provide additional
models.
momentum along the greater curvature.
So you get the idea. There's absolutely nothing on their site that talks about the cost. I have to imagine it's pretty expensive. You're going to use them up. You're going to need to get a new one and blah, blah, blah. And so that brings us back to the simulators. And this video
STEM now consists of skills,
shows you your
procedures,
classic
and link.
stuff from
Skills. The
Intuitive.
skills section is a constantly
And
expanding
Connie
library
mentioned
of
this,
simulation
and
exercises,
it's-
all optimized for
it's
surgeons at any learning.
better. It's
Over
definitely
30 of the-
getting better. Is it any good? Some papers have looked at this. Okay, so this was a paper about developing a robotic surgery curriculum using these various drills. Now on SimNow, currently there are 33 drills. And so they had experts going on and they decided that 20 of the 33 drills were actually pretty good. They said they were relevant, they were fun, they were difficult but relevant. The things that they didn't like, they found them to be easy, redundant, fun but redundant, unrealistic, confusing, difficult, and frustrating. So they're not all perfect. And this is just what we have to work with. Okay, so they were concerned that there weren't drills that were good enough for what they wanted to do, so they added on some of their own tasks, their own 3 drills, but 20 out of 33 was not bad. This was a paper that was a meta-analysis of a variety of studies that looked at simulation in robotic-assisted surgery, and it said that, certain surgical skills, like Hani said, really can be transferred to the OR using virtual reality, and it's fairly predictable. So they had a number of studies, thought it was quite transferable, and this is probably a combination of things is the way to go. So I will stop there, and we can go on to the next speaker.
Thank you very much. I really enjoyed that presentation. I kind of have a two-part question. The first is, as these virtual simulators improve, and as I think robotics become like the standard of care in how we do surgery. Do you think there will be a place for high-stakes testing? Like when I got my degree, I had to take the oral boards and the written boards. Do you think there'll ever come a time when there'll be like the skills part of it? And then the second part to the question is, how do you feel about, as in like the aviation industry, where people have to put in so much time over a certain period on simulators to make sure that their skills are up to date?
Well, I think the high stakes testing is coming, and I know that the American Board of Surgery is looking into, video-based assessments of surgeons as part of maintenance of certification. So I think it's basically, if not already here, it's coming very, very soon. Certainly they've been doing that in the Michigan Bariatric Surgery Collaborative, where they look at each other's videos and say, you're good, you're bad, blah, blah, blah. it has not yet been used to determine if somebody should have privileges, but I can imagine that the day is coming. And then what was the second question?
Just similar to what you were saying, just an ongoing requirement that over a certain time period you have so many hours on simulators. Because one of the advantages that the virtual reality systems offer is that you can get objective measurements. So it's not subjective, and you can actually establish like a threshold score and so forth.
Right. So it may not actually be time-based. It may just be skills-based. And like I was saying, intuitive insists that you get to, above the 90th percentile before they'll even let you go on to a wet lab. So I think that's totally appropriate. And certainly our residency makes the residents go through the simulators before they're allowed to even do bedside assisting, and they have to get a certain score before they can. So yeah, I think that's definitely here and is probably appropriate.
Professor Rogers, thank you so much for the talk. It's such a difficult topic. I went through the whole process through simulator cadavers, and then when I start practicing in my in my regular on my patients, I kind of felt like gone back 15-20 years when I moved from laparoscopic simulators onto patients. I still feel that between simulators and real life, there is such a discrepancy that is probably the weakness of the simulator. But regardless of this kind of comment, the problem we are facing now, at least in Oxford, and I'm sure in all the other UK deaneries, is that the trainees' curriculum does not reflect the robotic practice. In other words, some will be able to say, oh, esophagectomy pass level 4, that means competent, but that doesn't reflect this as was lap, open, or bariatric. Have you done progress in this respect in the States, and how do you evaluate?
Only in the sense that I think fellowships remain appropriate, especially with work hour restrictions for residency programs. And I have no idea if they even have that in other countries, but they certainly have it in the US. So most people graduate from their residency programs not really that capable in going out and independently operating. So I think fellowships are absolutely essential. And I think all of this training comes before that. And then you spend a year or more in your fellowship getting shrieked at uncontrollably by people like me while you're actually operating on human beings. And I don't know of any way around that. I think that's going to remain essential.
Thank you.
We have a comment from the audience. Somebody, I think we all know, Dr. Ragula. He was just commenting that he thought in robotic surgery that the perioperative staff was very integral to the functioning of the surgeon. And I certainly agree with this. How do you feel, Dr. Rogers, about this, and potentially with these like simulation models, training models, integrating the perioperative staff?
Yeah, I don't think that the perioperative staff gets much training whatsoever. And in fact, a year or two ago, my hospital decided we didn't need dedicated robotic teams. So, and I found a dedicated robotic team to be absolutely crucial. So I'm getting people who may have had, just be taken into the back room and briefly exposed to, oh, this is a robot, but not necessarily know anything about it. I was with somebody recently who I said, okay, let's undock. And she just stood there and I said, can we undock now? And she said, well, I don't know what that means. So yeah, it's really a problem. And, I don't think there are enough hours in a day to get people appropriately trained, and they should be in dedicated teams to really learn how to do this stuff.
I would like to ask you, well, when we train or when we learn, there are some difficult or some easy things to teach, and in technique. And I mean suturing, for example. It's not difficult to teach suturing in any kind of platform, or either dry lab. You can, on a dry lab, just train very well your suturing skills. either by laparoscopy or with a robot. But there are other technical aspects that are not so easy to train, and I mean it's mainly dissection.
Yeah.
So the dissection, either in bariatric surgery, mainly a revision, a difficult revision case. I do a lot of oncologic surgery also in colorectal. There's a lot of dissection. It's very difficult to teach or to train dissection. Of all platforms like wet lab, virtual reality, wet lab, what would you think it would be better for dissection training, which I think is the most difficult?
I couldn't agree with you more. And I think, number one, it's absolutely crucial that they understand the surgical anatomy of the area where they're working, because they can't safely dissect if they don't even know what the organ looks like.
Yeah, that's very true. Sometimes when we are talking about training, let's say robotic training, we forget that first of all, they should know how to do the operation. So that should be first. Okay. So.
Yeah, no, I agree. And you know, on a fellow's first hiatal hernia repair, they don't even know what it looks like, right? So you have to explain to them, you know, this is what a hiatal hernia is, and here are the landmarks you need to be looking for. And then dissection is I often have to remind people that when you're dissecting robotically, it's just like in an open case, mwah, 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 that sort of stuff. And, you know, everybody's done some open surgery in their residency. So I fall back on the fact that we need fellowship training. I don't think any of those other platforms are really that good at showing you how to dissect.
Excellent talk. I have a question. This training is essential to solidify movements and improve the performance. Do you believe it's necessary to go to cadaver, pig, and simulator, or do you what is there an ideal number of hours to complete this stage of training?
I think it depends on the person, because when I went through the robotic training on the XI robot 5 years ago, I was already an extremely experienced laparoscopic surgeon. So I don't feel like those steps were necessary, but they might be quite necessary for somebody who's newer in their training. And I don't know, I think it's individual how much time people need in order to get it. I think they're just going to figure it out when they do get it.
Okay, thank you.
I see a hand up. I think you're muted.
Paula, you have the...
Yeah. Just one comment. One of our challenges sometimes when we are proctoring people is just to teach how to do to use the machine, how to use the computer. But sometimes we have to train surgery. Sometimes it's difficult because sometimes the people needs to learn how to do the surgery, and this is a challenge.
It's a huge challenge.
Yes.
And I have to admit, going through your 3 proctored cases and then being turned loose is like kind of shocking, because it takes a year or two to go through the troubleshooting of all the different things that can go wrong with the machinery itself.
Very often you go for a proctoring on robotic surgery, and you just find out in the beginning that the surgeon doesn't know how to do the operation. That's why I asked before. That's a different thing. That's another thing.
It is somewhat terrifying, and that does happen. And you know, you're not going to be able to teach that in one proctoring session. But troubleshooting the instruments, that's where you have to do what Hani says and maintain your relationships, not just with your proctors, but people you find who are good at this, and then just call them up and say, hey, what the heck? What does this mean? What do I do?
So maybe we can go for the next lecture. I will present now this is Professor André Teixeira. And Professor André Teixeira will talk on observership, bedside training as a robotic fellow and established surgeon. Professor André Teixeira not only is a very good friend and very old friend, but he's also a robotic and bariatric surgeon in Orlando Health Weight Loss and Bariatric Surgery Institute in Florida. And I think he's running, I'm not sure what I'm going to say, but I'm almost sure maybe the highest volume robotic bariatric surgery center in the world now, I will say. So, André, thank you very much. And you can start.
Thank you for the introduction. I think Gloria has my lecture because I'm in between. I'm doing a trial here now with magnets too. So Gloria has my lecture, so I'll stay also on for questions. She's going to play the lecture. Gloria?
How training robotic surgeons from observership to a robotic fellow and then subsequently to established surgeon. Let's see if I can be able to deliver that. Because as you guys know, I'm a robotic surgeon. And at the time, there was really not a robotic training. It was everything we learned as we trialed and so forth. And my path was with a different system, and we had to take stepwise. There was really not a way to do courses. There was really no observership or training or anything like that. Everything at that time was dedicated to general surgery. But anyway, it worked. So let's go. So this is a learning curve path, right? For you to get to the expert level or good outcomes level, you have to start somewhere, right? And then you have to dive in head first, no questions about it. For you to do a progression on your learning curve, even today, I still make little changes on the way I do the procedures that the more I do it, I see some difference in outcomes and some difference in time and so forth. This is my learning path on a switch up to 2023. I'll say the switch all included here. Bypass and then sleeves, right? I didn't put revisions because revision is very tricky. Revisions you have to, there's some cases are longer, shorter, just really depends on what you're doing. I don't consider a sleeve to bypass a revision. I think it's just a conversion. It's one procedure to another. Half of the procedure is already done. So that it would be more difficult for me to kind of give you a learning curve on a revision perspective. But for you, again, you have to dive in. Dabblers that only do one case or once a week, and then the other, they do lab or they do open, whatever it is, they're never going to progress or pass that learning curve perspective. To make it an expert, I always think this is a really good thing. It shows that outstanding performance is the product of years of deliberate practice and coaching, not of any innate talent or skills. For you to become better at it, right, you have to practice. I'll give you an example. In America, we pretty much have the intuitive systems, right? Recently, we started getting approval FDA, CMR, Levit, and so forth. I've been to another system, done some cases that couldn't really tell the difference. right? In between, as we thinking in systems, doing the case, it was very similar to me. But why? Because I've been exposed to different things. So for you to understand that, you still to immerse yourself into this new pathway. You have to start by introduction of robotic, right? I mean, it's a 13 billion reach if you think about it by 2026. It's a big market, right? Intuitive alone has done 12 million cases and expected to be more, right? I think the competition is going to be bigger the next 5-10 years, which is going to be beneficial for us. Robotics are here to stay, no questions about it. Like, for example, our hospital, we have 26 XIs, 3 ions. I think we bought 2 DV5s now. And then we have, you name it, in terms of neurosurgery, vascular, plastics, robots. We have pretty much almost everything. So the hospital itself is very deep in technology. We are looking at patient outcomes. If it makes sense to enhance patient outcomes, why not, right? It is well known the data. If you compile the data, the meta-analysis shows that robotic surgery results in 50% less blood loss, right? Reduced pain, faster recovery compared to traditional methods. Technology advancement, no questions. AI, I mean, now you have AI in your telephone and so forth. So AI is going to come part of it. And the DV5, for example, data analysis is pretty impressive. You get your report hours after you finish your case. So the analysis is there, and it helps you to guide you in a different way. I foresee the AI with the robot and the surgeon, the AI will kind of hopefully guide and develop a pathway to guide the new surgeons in training. Of course, it starts with observership. I think before that, it starts with the curiosity in terms of the technology and trying to figure out something different and better for you and for your patients. Observership is always a great way to start. I think you go and see people, you learn the workflow. What sometimes people forget, they come in just to see the surgery. You should look at everything, how the whole OR interacts with the system, how the workflow is done, how is the OR versatile in technology, and build foundation skills. Those are very important. And then you have include talking to senior surgeons, discussing ideas, methods, how they approach it, why they approach this way. Simulators, it's a good way to start too. And then they usually ranges between days and months in time frame. It depends on how much you have an opportunity to observe others. And then you have to do your basic robotic training certification, right? That's how you start. Usually it's a hands-on skill development for you, junior fellows, or in this case, in the United States, depending on which program you are, you're already starting your residency. Most of our resident body here, by the time they are 4th or 5th year, residents, they are so versatile in robots, it's pretty impressive. We can actually see, especially when I have fellows that come in that have come from programs that are not really deep into robots, there is a huge discrepancy in learning curve from their perspective. But in skill acquisition, they're going to perform basic robotic tasks like camera control, suturing under supervision. You have to, the red things I think are important to me, engage in hands-on training, often begin with minor procedures, assessing assisting senior surgeons with docking, undocking, camera, exchange of instruments, gradually moving forward in your tasks when you're in the console. Learn about preoperative planning, post-operative management, and then give a certificate in a course. It depends on which you're doing. If you're doing intuitive here, you get a certificate right away. It's a 1 to 2 day course, depending on what level you are. But then the development of those junior skills, if you're involved with a program, it can be 6 months to a year. That's usually what we see the traditional for our residents and junior fellows. Then a fellowship, like when the fellows come to our programs to do robotics and bariatric. Some of them, like I said, have done much in robots, so there's a whole process to it. You start before hopefully teaching a little more complex. Sometimes you have to start from the basics, which is like how to control the camera, change your instrument force, right? That's a big thing. The DV5 now you have force feedback. So for new trainees, I think is great. But for older surgeons that have been doing robotics for many years, I'm not so sure that's worth it. But still, there's a different data point that we need to figure out. So you start assisting gradually perform robotic surgeries under guidance and expertise, developing proficiency, which is very important. I think I tell them is avoid waste movements. That's one of my pet peeves. Perform increasingly complex parts of surgeries, managing complete cases from preoperative assessment to post-op follow-ups under supervision, of course. Then, okay, this fellowship is really focusing on honing your skills, get you better, specialize in your field, like for example, as bariatrics. Of course, the fellowship is 1 year, but usually after that, and depending on where you are, if you're in a very busy program, 1 year is more than enough. Our fellows here finish with about 500 cases each, so they're super well trained in terms of robotics. And then you have the mentorship, proctorship, right? Transition to independence of your practice. So once you move to that practice, you've done it already, all your training. Now you try to figure out how to become a mentor or proctor, right? I mean, you mentor overseas complex cases, providing feedback, refining techniques and decision-making skills. I'm always in the phone exchanging ideas with different people, different cases, request for assistance, for help, discussion. We use technology now to kind of jump in the cases and help them out. It typically lasts for about several months to a year, depending on your skills or confidence level. And I think it's important for us to understand where the future of training is coming to. I think AI is going to be a big part of it. What I talked to you a little bit was more traditional, but I think this is what some of the things we're implementing now. AI enhanced precision, allow AI to allow real-time diagnostic image guidance, navigation, heighten your surgical experience and precision. So I think that's where AI is going to need to go, the system. The expanding autonomous capability, that's going to be interesting. I think with the AI and that capability allows you to correct the movements as the surgeon is trying to do the case and having difficulty. It kind of guides you. And then virtual reality, I think virtual reality is huge because it allows you to see some different paths even before you do the surgery. It allows you to kind of do the procedure without doing the procedure, have an idea of your work frame, where you're going to go. Of course, all that has to do with 3D reconstructions and so forth. Hands-on robotic observation, where you're going to jump in from one system to another from different places, which that'll be a great way to do the hands-on observership. VR simulation, as we talked about, customized learning pathways. Depends on what you want to do, where you are, what specialty we can customize and assess that too, with all 3D guidance, VR, simulation labs, and AI. And then the same thing, it's just in skills and certification is going to be a lot different. In my mind, you still have to do that basic part, but now you're going to have more simulated hands training. I think the simulation is getting better and better and better. You're going to have AI assisted skill assessment, which allows the real-time feedback and repeating or changing the difficulty of the scenarios so you can pass different scenarios. And then certification is going to be almost the same thing, but just with the AI and the enhanced simulation component. Same thing with a futuristic mentorship and proctorship. You're going to have an AI augmented feedback. No questions about it. That is coming down the pipeline. A virtual core surgery. That's some of the things I think about it. My head is out there. The virtual core surgery would be like almost like a pop-up and tells you, hey, I think we should do this, we should do that. some kind of theory for that matter. Proctoring, teaching role models, same thing. Proctors leverage VR and AI to guide junior surgeons, establish standards of robotic excellency. Of course, a lot of these things were my ideas come out of my head. Hopefully, this can become real. Advanced autonomous assistance, it kind of help you and guide you on all your procedures, like we talked about it. Continuous learning is innovation. This is important, right? I think for you to become a very successful independent robotic practice and leader, you have to be part of innovation, research, continuous advancement, contributed to the field. I think is a big thing, right? Contributions, pushing the boundaries of robotic surgery, like different things like we're pushing now. Recently, we started using 1.9 millimeter orthoscope to do some laparoscopy diagnostic things. So it's 1.9 millimeter, right? So looking where it's around you and trying to push a little bit more the envelope. The final path, again, achieving expert status, contributing to the field of training others, because it's a pretty honor situation for you to be able to be part of that and do that. Leading robotic surgery programs, becoming a proctor, a mentor for junior surgeons, publishing research, presenting at conferences, and possibly develop innovations and techniques in robotic surgery. Advocating for best practices and safety standards in robotic surgery. Again, this is an ongoing duration. I don't think there's an end to it. I think the day that I feel like I don't have anything else to contribute anymore, that's the time for me to retire. And hopefully this is a long time away from now. But this is what I see from an education perspective. I did not have none of this. I wish I had it. But the people coming now are going to have a lot of this stuff, and it's going to make them a better and a safer surgeon, no questions about it. Thank you very much for the opportunity to participate here. Open for any questions now.
Andre, thank you for your talk. Very nice talk. And I had a thought, and I wondered, I wanted you to weigh in on it, and also I'd be very interested, Dr. Rogers, in your thought, given your position within ASMBS. But it's really exciting to me to see the advances in mentorship and proctorship in terms of what's going to be allowed, because historically it's been tremendously taxing in terms of time and effort, especially to mentor people outside the country. It's a lot of time you have to take away from your practice, and a lot of that is going to be done virtually. And the other aspect of that is that we're kind of in a select group, but there are a lot of surgeons out there that don't have somebody they could just pick up the phone and call. So if I ever had a problem, I would just pick up the phone and call Kelvin, and he would always know the answer to everything. So that was like my go-to person. What are your thoughts on, like, if societies created like a committee of people that were very experienced, that were just available to the community, and it would be a group of people, and I think the technologies will be there where you're in the OR, you have a complicated situation, you could link up, but basically providing a group of people that they can reach out to, and that would be available for everybody.
So, Keith, I think this is a great idea. I think all of these kind of ideas, what the problem we have is liability, right? When every time I got involved in proctor, that's why I don't do proctor too much, because I had a really bad experience with a proctorship. We got there, I thought the patient was going to die. So I didn't want to get involved in that anymore for that reason. So to me, it depends on the legality of things. If it makes sense, I'm all for it. I think we need that for sure. I don't know what Ann thinks about it, but I think that's the biggest hurdle.
My approach has been based on those Facebook groups that Hani was talking about, because you watch enough videos on those things and you can see who's really good at this, right? So whenever I encountered a clinical issue, I would reach out to those people that I knew from the group, like Hani or like Andre, who are just clearly good at this, and ask them how to find a way around that. And the answers were forthcoming immediately. And it didn't even require having, people set aside by our society. They just are out there and they're well known.
I think people sometimes just they don't feel comfortable picking up the phone and calling or just asking the question. I think that's a first start, right? Just pick up the phone, ask the question.
Absolutely. And when you're harried enough by the problem, and we'll be frank, I mean, when people start doing robotic bariatric surgery, I think a lot of people start finding JJ obstructions that they were not having laparoscopically. And it's just because it's a different operation. It's not the same operation, just
It's a
being
different
done
technique.
with the distance of a robot. It's a totally different operation. And there are approaches. Hani showed you one of them, that just the turning of the instrument, to mitigate that. And if you're hysterical enough, you'll call all sorts of people to find out what to do to make that not happen.
It was very interesting to me because I started robotics pretty early when a lot of people thought it was a bad idea. But in the beginning, I had a lot of people come to my OR and watch a case. And then I would run into them in meetings and stuff like that. And I would say, hey, how was it going? And they would go, oh, man, I just gave it up. And so the vast majority of people would try 4 or 5 cases and then just give it up. It wasn't until I started understanding that people would come and I would say, well, put your trocars where you normally would. It wasn't until I started understanding it had to be standardized. I had to tell them exactly where to put the trocars, exactly what sequence. And then more important than that was just this idea of longitudinal engagement. So I never proctored in the US. I proctored a lot outside the country, but it wasn't like a proctorship. It was a friendship. And I think, the element that, there are a lot of surgeons in this country that don't have somebody they know that has a much higher level of expertise that they could reach out to. But it would be amazing if they did. We could create a platform where no matter who you are, you call this number, you're going to get somebody who wants to help. I completely agree about the legalities, but I think it's something worthwhile we should pursue.
Yeah, but I think it would be something like SRS can do that too, right? I mean, that's your robotic society right there, right? So it's something wanted to be spearheaded by someone. Probably that would be the best one to spearhead it, right? Number 2 is, I agree with you. Back then, there were very few people doing bariatrics with SI, including myself. And most people that we proctor, they never went to the next stage because it was a different beast, right? I think with the XI robot in America, I'm talking about, that really took off, right? When people got comfortable with multi-quadrant, you could replicate a lot of the things the techniques and so forth. You were able to operate in different quadrants. It made a big difference. I think that's why with the SI, there was not really a big takeoff on people using it and proceeding from observership to actually doing it.
I agree. And when you go to observe somebody like Dr. Keith Kim, where he was at the time, he had resources and facilities that just I couldn't replicate. There was just no way I was going to be able to do it.
I just have to confirm, and I've been a witness of what Keith said about his proctorings abroad, that it was mainly a friendship because I learned from him. So he was my proctor, my mentor. Now he's my brother. But actually, his proctoring for me, it was something amazing. I went one week maybe to see him in Orlando. And then I would go to start my operations on next week. And he just came along, not just by himself. No company brought him, not my hospital. He just came for one day from Orlando to Lisbon. And he stood less than 1 day in Lisbon proctoring me 2 cases, and he went back. And that's how he proctored me. So it was really friendship.
André?
He was running from the law.
There is one question here from the chat. It's the same thing that we have heard about it, but one member is commented that given recent publications demonstrating cost disadvantages and even clinical disadvantages to robot versus laparoscopy, bariatric procedures. Do you agree with that? It's one question of the chat.
So I disagree with that completely. I think, Paulo, we had many conversations about this, and Keith Kim, I have conversations to everybody. I had a conversation with about this. I think it really depends where you are. We always forget cost is, surgeons are very horrible in costs. They don't know how to calculate cost of things and look at things for sure, right? So why would a company that I work for, an $11 billion company, have 28 robots, 3 ions, 2 DV5s, and so forth, so forth, so forth? Why would we buy this amount of robots if you're losing money, right? It's actually the opposite. We make a lot of more money for them. So I don't think we should generalize things. I think different countries have different issues and different costs and so forth, no question about it. But remember, different countries have a lot more platforms than what I do. I only have one platform that I have to work with, and I'm able to make work very well. So I have a hard time with that, super hard time in papers like that, comparing costs like that, because they never take in consideration, for example, the standard cost of laparoscopic equipment. They're not just there. There is a cost, believe it or not. Most hospitals are already in place a couple of $1 million every 3 or 4 years to buy new laparoscopes, right? So it's already part of the budget. So they don't take that in consideration. Well, you should take that in consideration. That's a cost. So for me, I have a hard time with those things. I refuse to discuss those things anymore. I'm already past that point. My goal now is like single port, endo, robotic stuff. I mean, AI. I'm already past that point. I love to teach, but I'm already past that point.
I totally agree with you. We have the same
I couldn't
opinion.
agree more. And nobody's taking into account the cost of replacing surgeons and the fact that this is extend our surgical lifespan. And so they always talk about value being how much it costs for patients and how well patients do and blah, blah, blah. And it is hard to show that robotic surgery is any cheaper than laparoscopic surgery overall. Yeah, it's hard to show that. But at the same time, the cost cannot be the only thing that we take into account. Because, for example, if Wile E. Coyote had to drop an anvil on my head and then it was going to be cheaper to do the operation, well, that operation wouldn't happen, right? So we have to take the surgeon into account, not just the cost to the patient.
Thank you very much. Very fascinating discussion, and stress the importance of training in robotic surgery. I mean, for the sake of time, I will skip my question, and probably Professor D'Almeida should introduce the last talk. Thank you.
Okay, thank you, Sgromo. It's a great pleasure to introduce Professor Ramon Villalonga Puy from Spain, head of the Endocrine Metabolic and Bariatric Surgery Unit, Volpe, Barcelona, Hospital Campus, Spain, and Professor of Surgery at the Autonomous University of Barcelona, Spain. He'll talk about operating with a proctor or robotically trained surgeon. Let's go.
Yeah, so good afternoon and good evening. First of all, I would like to thank everybody and obviously the kind invitation to participate. And I have to say also that 2 of my mentors are also here, as Carlos and Keith trained me, and they had the opportunity to come in my hospital both. So a little bit of this feeling, no, that I will try to show of how things change it now for a surgeon compared to what used to be, and especially what could have been done. So I work in Hospital Vall d'Hebron. This is a big and large hospital, and I have to say that we were lucky to be the second hospital to include this technology in our daily practice. Unfortunately, this technology at that time was yes. Can you hear me?
Yes, we can hear you.
Yes, very well.
Okay, there was maybe a micro on. So let me tell you that for Spain at that time, it was really a novel technology that was very that was very difficult to explain how to buy such a robotic system for this country. And we had some previous experience in Europe that we will discuss now, and see how then we can train a surgeon while he's doing the case in the OR. So I'm also proctor for Intuitive in Europe for bariatrics. And for example, now we are designing the wet lab advanced course for the phases of laparoscopic. I wouldn't like to forget my third big mentor I've had in my life, which is Jack Himpens. I spent him nearly 2 years of my life. He gave me data on regarding all this, but he also opened me a vision, and we also did the first bariatric Belgian case at that time from Dendermonde. However, he with Guy Bernard Cadier were the ones to start the bariatric cases somehow. I would like also to mention that this concept has come and has been mentioned. For us also, when we take a surgeon who has probably done a curricula and wants to be launched on real scenarios, probably he's already a person who is engaged, who is willing to learn, who's motivated, who's enthusiastic. But we need to understand that this has not been easy for no one. Although I have to say that nowadays the young surgeons, and I would say at least depending on the facilities you have had in your hospital, depending on the country and the accessibility of the training, especially thinking in simulators, the possibility to be a better surgeon when jumping on the real case, this is very important. But we need to understand that there was a lot of frustration in the beginning. And even if we are training now surgeons who have already had previous training, previous simulation, we always have to think that there will be at a certain stage of the procedure in this type of advanced skills and advanced development of his surgical area. So a certain degree of incompetence that might be unconscious or conscious. So we are always learning, we are always evolving, and we have better improvement of our skills and at the end facilities to operate on different type of cases to become somehow an expert. And this is very important. We have also to disclosure that the bariatric surgeons weren't the first to jump on the bus of the robotic surgery, even in the United States, so even less in Spain. So in Spain, for more than 5 years, we were a sort of desert in the country. Some strange people that were doing strange things with a strange machine that was costing a lot of money. So we didn't find a lot of references. We had to go to look on works on the USA, the first short series on Italy, a couple of groups on Switzerland with Philippe Morel, of course, but also very short publication of cases, which is some of the limitations we had at that time when we think the beginning of our process of implementing this robotic technology in the bariatric field directly. And that was very important to explain, because we didn't have any kind of references to learn, to better, and to improve, and to even be trained. At that time, remember, there was only intuitive based in Strasbourg, and you used to do a 1.5 day course while learning how to dock the system, put instruments, do maybe an anastomosis, and that was the certification we used to receive. There was not really any specific online training, online courses, not even virtuality. However, we went ahead, but that was the bad way to be trained, and that was the bad way to learn. So it was very difficult because there was an increasing demand of cases. We had to learn, and we had to go to experts, although at this time we had the vision to try to consider the sleeve gastrectomy as a first procedure in order to navigate and move arms without stapler, but trying to avoid more complex procedures. Probably at this time, that was our thought, and this is how we did our learning curve on the patient. Unfortunately, that was the old times. We still had to say that we learned to do better a sleeve gastrectomy with 25 cases. But unfortunately, this and hopefully this is part of the history, and we could have seen that. So really, the learning was very unclear. With the publications were mentioning the famous 100 cases of gastric bypass with that technology at that time, the only robotic platforms. We will see what will happen with the training in other robotic platforms. Do we have general concepts of each technology? We will need to know about the technology, but we will need to train under different consoles, under different environments, and train also the non-technical skills and the communication skills in different platforms. And platforms will come, and so we will need to have a general curricula, but then we will jump on real case on robotic. And this is really the persons that were able to come, no, here with Kid, with Carlos, also with other very known and reputable robotic surgeons, and this is really how at that time we were training. We had the chance to do dry and wet lab, and we were even organizing this type of courses in 2012, and that was the best way we had for us to train, because at that time it was not so common that the same intuitive gave us the facility to train on a pelvic trainer with the robot, and that was not so easy as I can do now with my young surgeons that I have in the team that I am proctoring, but also with other times. So in the old times, I would say that there was another situation. We had to deal with other platforms, less cases. Bariatric surgery was not the relevant specialty. So we had to fight our cases to get the robot platform to be trained ourselves. And really, the training was this case observation that Carlos Vaz was mentioning, and with a proctor at that time, more expert than you, that could even do the incredible thing to come with you for the first cases. So now what we are doing, but we are doing that in a more organized way. If we think on some data related to persons who get courses from, for example, the IFSO or even the AHS, they find that the program and the skills acquisition is very important. So they find that, and they accept that before now going to the real case, you need to be trained. You have the tools to be trained, and these are lots of the things that have been mentioned. In which surgeons from have to see the fundamental surgery, the skill. This is that happens. Ask the before we are cases with there are different of curriculum and the expert things, and this is very important to be mentioned. This is something we add in our patient. This, for example, is is a training with a double console in which we are experiencing with a dry wet model, but we are performing gastroenteric anastomosis, and we show what
It seems like the problem got worse and worse. Unfortunately, it was a very interesting talk. We can probably, I'm going to, Gloria, I don't know if you can text La Longa to see if he can connect back.
Well, we're waiting for him. Anybody have any questions?
He's back.
Okay. Oh,
Ramon
is
is
he
back. Ramon, you're muted at the moment.
So I think, did you get this slide?
No, we didn't. We could see you and two trainees at the double console.
Okay.
Here
So
it is.
that it is. So this is what we are training. So we are now training, and this is an obligation before we go to real case of the training. And I was mentioning that was the course we really loved to do. For example, last week, in order to see whether we can include the fundamentals in robotic surgery. Remember at that time, Rick Satava that showed already that the exercises required in robotic were going to be more complex compared to laparoscopy. And these are things that we can really include in our practice. This is an example of what we trying to do in the experimental lab before going to the real case and using the double consoles. And this is how we train, for example, 8 surgeons in bariatric surgery, because it has had an explosion of robotic systems implementation in Spain. Now we have more than 104 platforms of Da Vinci Intuitive in Spain. So it means there's a lot of robotic going on, and there's a lot of need of training. When we think about the perception of the fellows that want to come to our center, we need to try to assess a standardized. And what they see is that they haven't had a real clear curricula. They knew they had simulations. Some did it in her hospital. Some went to someone's hospital. They did some dry lab with the same company. So really, they suffer during the residency program. I have to say, however, that our residents have a specific curricula in robotic training during the residency that they can allow them to do some parts of the procedures while they are residents in each department: colorectal, abdominal wall, esophagogastric, bariatric. And so this is very important. And they understood, and this study showed that most of them didn't have a real assessment. So I think it's very important to find a strategy. I don't know if country dependent, company dependent, academic society dependent, to standardize a robotic curriculum. And I think now even more important that we will be more platforms before doing the proctorship with the real case with a proctor and an expert, because really is an opportunity to find out. And so this is what we did. What I can tell you is that when I have the double console, because I can do an XI without double console, XI with double console, or SI. So the SI, I do the cases and I train them how to do a bariatric procedure in SI. But when we have the double console, this is very important. Unfortunately, there are few data showing the usefulness of double console, specifically in bariatric. But really, this is, for example, my training in endocrine thyroid surgery with Marco Raffaelli from Rome. And you can see how we could train together in this way. And this is, for example, how we let the movements to the medical students, but also our residents are able to do some procedures. And here, obviously, I am recording, but usually I am in the other part of the console. And here there will be enteric closure, the pass through the. This has security, high ethics. What is good is the easier scale, avoid metabolic problem. We're not looking for wide diameters in order to have less problems with the trocars. Look for low abdominal fat, better probably them to be trying. I think there should be a stage in which they cannot pass to the real case without a real previous training, virtual or even dry or wet training, especially the dry one, that we can do it in the same operating theater in the afternoons with the same robot. So they have a lot of facilities. And then it is very important to understand how they deal with the function of the beta system. As a primary surgeon, when they are moving more instruments, or for example, they access arms 3 or 4, and learning the communication skills. It's very important to show how we must communicate in the robot. All these things are training. So it's very important to understand this, and in a gradual way, in a process, as Dr. Teixeira was mentioning, it is a process of the teaching of a proctor. And we feel confident little by little to let doing some steps. How we do it? For example, we do the sleeve dissection one day. Maybe we have 2 sleeve gastrectomies robotically assisted, and then we do the sleeve dissection. Why not focusing on the stapler? We do the sleeve transection. This is how we do. Little steps to avoid the trainee to be tired, to avoid ergonomic lesions, but also to let him understand that he wants, and we need to focus on this step. The other one, we see how we do it, then he tries to learn how to do it. We also like to start with Peterson spaces, with the with the gastroenteroanastomosis, with counting the small bowel. I like them to try to train how to count the small bowel. I can do that. They try to reproduce the same, but unfortunately, it's not so standardized. I need to avoid to have a waste of time on real cases. I think we cannot do a gastric bypass in 5 hours just because he wants to do it and he has to do it. No, he has to do specific steps, and the learning curve will go ahead even in a better conditions. Show the way, the double console, train with predoctorate videos. We record everything and understand the basic principles of laparoscopy in the robotic field. All these things that have already mentioned have to be implemented also in the real time, but on the real case, obviously. And this is a real scenario of one of my Tuesdays in which I'm proctoring, I'm just seeing, and I can give and take the commands. And here we have our young surgeon who is operating, and we have the residents who are trained as a bed assistant surgeons, because it's the plan we have with them in order to train. And specifically, they can do some of the cases. With this, we've got good results. With the technology had a sleep by operating curve. And finally, start, I would like to many to do so in review for the data on which procedures were done before, how they adopted the curve was done, and which and the technology. Obviously, everybody focuses on operative time, and few papers focus also in other aspects like leaks, like complications, and other different aspects. So the learning curve for according around 50 or a little bit more. Probably the most serious papers
I think we lost Dr. Villayanga.
It seems like it's a very unstable connection. Oh, Ramon, you are muted.
Yeah. Can you see my presentation? I think now it's better.
Yes, yes, we can. Just for the sake of time, I think we are.
I think, yeah.
Carry on.
This is the paper I was mentioning. I think you did a number of cases. I was mentioning that really when we look on the literature, the variability is always a lot related to a lot of variability on prior robotic procedures. We don't know exactly how they did the learning curve. We don't know exactly how they adopted the technology, and obviously a lot of papers didn't mention no more about the number of cases, and they found different aspects to do that. So at the end, by the end, we can do some specific steps, and this is a bypass done by one of my fellows. So as other technology, we need to be aware on learning. We need to learn how technology works. There's different ways to learn. Nowadays, we have a lot. We need to think on and talk about how to do real good training. Understand technology. I think we need to understand works, and probably the issues deal with how to adopt novel technologies and platform mentorship, and understand how little by little we can. To conclude, let me tell you that training is a challenge. We need to have at least a plan for them. We need to revise this plan. We need to recheck this plan and go back if necessary in little steps during the real case patients. We need to have a high ethics quality as a surgeon, and this is very important to be understood. Obviously, a lot of persons can be trained. We have trained a lot of people, but obviously there will be always the mentors that train it to you. So I am now finishing to share the presentation, and I thank you all very much again.
Thank you for a very, very nice talk, Ramon. In the interest of time, I'm going to refrain from asking any questions. Any of the panelists or other speakers have any questions?
Thank you for the terrific talk, Ramon. Thank you.
So I want to take a minute to thank Dr. Harris and Dr. Ortiz for putting this amazing event together. I want to thank all the panelists and the speakers and the moderators. And I think this is a very, very important topic, and I want to congratulate everybody on the role that you have in mentoring other surgeons around the world. And it was a pleasure being a part of it. Thank you. Bruno, you have any closing remarks?
Just to thank my co-chair, Professor Kim, and all the speakers and panelists. Really, really important topic. Thank you very much, everyone.
Thanks for having us.
Thank you very much.
Thank you very much.
Thank you very, very much.
Thank you, everybody. Thank you very much.
Gloria, we can hand the webinar.
Co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete hot topics in surgery, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars as the 6th IBC University of Oxford World Congress will be taking place September 8th through the 10th of 2025 at the University of Oxford, United Kingdom. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
Intuitive Da Vinci 5 is our most advanced and integrated system ever. It's going to transform surgery for surgeons, care teams, and patients.
I've never seen anything like this before. Force feedback is a first-of-its-kind technology. In preclinical trials, we're seeing up to 43% less force on tissue. That translates to gentler surgery for patients.
Before, we relied on visual cues primarily, but now with feedback, it does give you that extra sort of sense.
It's not something I've seen with any other system. It's something we experience in open and laparoscopic surgery, but not robotic surgery.
We're going to be able to control so many more things from the surgeon console now, which I think is really important.
It's really an immersive experience that gives you a next level of control that you didn't have previously.
The ergonomics, the ability for me to move the headset where my head goes in and move it exactly where I want it to be in a variety of different positions. I think that really is going to help elongate my career and make surgery more comfortable.
We are seeing Da Vinci 5's capabilities result in faster surgery, which translates to our customers' ability to do more surgeries in a day.
I think having the integrated new components will make the process of starting the case a lot more efficient.
The insufflator being in the vision tower is just a huge thing.
We don't have multiple vendors within a tower. We literally can offer everything that we need for the patient under one umbrella.
I think it will make rooms more organized, so helps with the staffing problem that we have, and also helps to reduce the cost.
Da Vinci 5 will help surgeons unlock new answers to surgical techniques and patient outcomes with unique and granular data. Da Vinci 5 connects more data than any other platform that I'm aware of and allows physicians and their administrators to link them to patient outcomes.
This opens up an opportunity for years of innovation and years of things that are going to come next.
I can't wait for surgeons to get their hands on this.
Now we have a platform, an approach to do minimally invasive surgery that is beyond anything that we could have seen in those incremental improvements. And that is what's giving us the magnification, the stability, dexterity, ergonomics, precision, all of which are key for us to be able to provide the highest quality minimally invasive surgery that we can to our patients.
We don't want to be behind in medicine. We need to be ahead, and that's what's really exciting about this next generation.